I'm Jessie Tyler, or Jessica. I work out of our Austin office, and the Austin office is primarily concerned with data and data evaluation, so that's what I'm here to talk to you about. So when trying to document the impact and ensure sustainability of your program, these will hopefully be some nice directional tips in where you can go for data and how you can maintain these experiments. So basically what I want to talk to you about first is the role of data in decision-making at various levels of the policy-making process, and then go through a minimum level of effort for data, just sort of a floor where if you reach this point, then you're going to be able to not only describe your program, but talk about how it fits into the larger overview of the criminal justice system in your area. And then I'm going to start talking about data and its impact on sustainability, and then I'm going to quickly sit down and turn it over to Anne-Marie to talk about her actual experience in using data to sustain a program versus the theoretical aspects of how one would do this. First, when we think about data and decision-making, we need to remember that there's actually three different levels, at least from where I sit, as to what it needs to say and to who. So elected officials are looking to use data to help close the gap and find the sweet spot between good politics and good policy. Whereas, when you look at the fiscal or grant managers, they're looking to make sure that the grants and programs are having the best performance possible. So they use data to help in administering their program. And then finally, the program recipients or indirect users of this data are looking to make sure that they're in a program that is beneficial to them and is going to help them, in the rest of their life. And definitely don't want to be in a program that's going to, harm the participant. I think, some of you are probably familiar with some of Dr. Latessa from University of Cincinnati's work, where, the best example of this, where you don't want someone in a harmful program, is you think about, juveniles. They've had a little bit of trouble with the law, maybe some, dabbling into some soft drugs, and, this is definitely not an outcome that we're looking for with these kids. But, the program response to it is to not put them into a drug program with, hardened juvenile offenders that are doing, big drugs, because this is just going to drag them into that lifestyle instead of, benefiting them by moving them back toward a more functional lifestyle themselves. Specific to the elected officials, data is just one of many aspects that they're going to be considering when looking at making policy decisions. So, first they're going to say, is there an interest group that's supporting this program or this response? Is that an interest group that's important to me, that I've worked with in the past? I believe in their mission, or they're supportive of mine. Is this initiative going to fit into my worldview? And as cynical as it is, am I going to get good press coverage from this? If I support this initiative in these programs, is this going to be the type of thing that I want to project as something that I could campaign on in the future? And data is sort of in the end of this and helps close this gap. If I have a program that shows that it's cost effective, it's beneficial to the community and the participants, this is a good way to get good press coverage. So they're definitely going to help. If you can show that your program has worked, the hard numbers are going to help the elected official lend support to the program. And when it comes to an administrative level, the questions that they normally ask are, can I account for the use of funds? Yeah, you probably already are. Is the program well managed? Probably. I mean, you're not going to have gotten the grant to begin with. But you're going to want to collect a good deal of evidence and data to show that the program is effective, that you have good outcomes, and that these outcomes would be better than if you'd done nothing. And did you do this for a good, cost per client ratio? BJA faces a big challenge to show how well your programs are working, as do you and your community. So, our goal is to help you guys collect some performance and outcome measures that are going to show program effectiveness and cost effectiveness. Finally, from the view of the indirect users of data, all the other questions kind of flow out of this data question. Does the data show positive outcomes for clients? And then everything else is just sort of a sub-question to prove if the answer to the first question is yes or no. Do we have a good completion rate? Was there a lot of complaints? Is everyone satisfied? Are some people unsatisfied, but it's for reasons that, couldn't have been helped? So, collecting and knowing this information, but then putting it together in a cohesive way to present to different audiences is a good way to show that there were positive outcomes for the client. So in doing all of this data collection, right, it sounds very easy, like, hey, just show that your program is cost effective and people like it. But I know that there's going to be some problems that you're going to run into, because these are the problems we always run into when doing this same work. So the first is related to the target population. Now, is there a way that you know that the people coming into your grant program are the people that you wanted to serve with this program? So we're going to want to use data to sort out participants. Now, I've worked with some programs where, they're looking to serve a nonviolent, severe mental ill population charged with a misdemeanor that haven't had any traffic violations over the last 10 years. And these are the only people that are ever referred to the program. This referral takes place behind the scenes without having anything to do with the client. So for those people, we know that they're going to be targeting their program to the right population, because that's the only population coming in. But not everybody has the same luck. So we want to make sure that you're targeting the right person, and that you would have data to prove that these are the right people. But not every data system captures the key elements. So a person comes into jail, they get an assessment, there's a result of that assessment, they're referred to treatment, they leave jail. I mean, that's probably 4 different systems: jail, the treatment, the assessment, and then, 3 systems: jail, in and out. But are we going to be able to get a hold of this data to prove that it's the right people? And even if the data exists, linking them to this individual client still, can present some difficulty, because the data systems don't necessarily talk across agencies. The next challenge area is in the administration level. So your grant or your program is purported to serve a certain clientele in a certain way through a certain process. But is there a process evaluation that's been done to ensure that this treatment will occur, and only this treatment? So there's not always a process evaluation done to show that the program is doing what it purports to do. And then, sometimes we run into some issues of confidentiality. Is this a barrier to collecting data from different agencies? Sometimes people don't want to share because they're, unsure really of what HIPAA says, or they, are just hiding, behind their confusion over these confidentiality policies specific to their state or locality. Now, there's an article by Dr. Petrilla at the end of this report that I referenced. So, if you guys have experienced these barriers, just, put a little star next to this, and I'll refer you back to that study at the end. But that does offer some ways to help overcome these confidentiality issues. And finally, pennies for research. Now, granted, I get paid more than, that looks like 45 cents, but when you get an amount of money to do, these programs, there's not always a lot of money within that block that's going to go into the research area. So everyone, wants to serve the clients and do the best job with the program, and, give the best assessments and do the best treatment. And so the money that's left over goes to research. And so there's not always, someone available that would be able to, spend all of their time looking at how to overcome these issues. Outcomes, that's another problem, although somewhat easier to solve. There's not always agreement on outcomes or how to measure them. This is something that needs to be done at the onset of your program. So we would be able to collect the appropriate data going through the entire lifespan with each client. And then sometimes there's just not really interest or expertise in setting up mechanisms to measure the outcomes. So, there may not be someone that knows how to set up a good, access form to collect all this data on the specific individual. But this again ties back to the amount of funding for the research in each area. And then finally, even if we get everybody on board and overcome our obstacles with confidentiality and agree on all of our outcome measures and get the best data possible, there's still problems conceptualizing the results in a policy-relevant manner. We want to be able to put things together in a simplistic way to present to multiple audiences. We already saw that there was 3 levels of decision-making that are going on, and the way that we present, what our program does needs to speak to each of those audiences. So, moving on to our minimum level of effort for data, this will should be helpful in overcoming some of those barriers and then giving some advice on how to present our information. So right back to the same headings. So identifying the target population, we want to make sure that we can get the right people in the right programs getting the correct treatment, and so there needs to be some effort done at the onset before we even start attracting people to the program to make sure that we know how many people that meet these criteria exist in the system to begin with and how many of them are being referred out to our program, which requires some talking with the different data sources and agencies that would house those data sources from the onset. At the administrative level, drawing a flow chart of the process of people coming through the criminal justice system at each, movement that they could possibly make with the different choices is a good way to begin the process of, drawing this flow chart. And so this will help you draw a baseline later, and it will also help you find if there's inefficiencies in the system. If certain people are going through the exact same decision nodes multiple times, if the same information is collected on clients multiple times, this will, help the entire system go more smoothly and more efficiently. And outcomes, we just need to start before we even accept the client into the program. What are the things that we expect our program to do for our clients? And then, how do we collect data that is specific to each of these outcomes? So we know that going in, and there's not going to be a scramble at the end to figure it out. One of the big outcome measures that we use a lot is recidivism. And there's 3 different ways to measure recidivism, which is rearrest, reconviction, and reincarceration. Rearrest is pretty easy to get. Reincarceration is pretty easy to get, but reconviction is pretty difficult. Court data is not set up for, research purposes of this type, and it's very difficult to link to other parts of the criminal justice system. So when you're thinking about the outcomes you want to see, I would say rearrest and reincarceration are the 2 that you should concentrate on. And I want to stress this so badly that I put it in bold in these notes. But what's really important for the recidivism measure is that you give everyone an equal opportunities to succeed in the community. So when you think about recidivism, it's not, on March 1st of 2013, how many of my clients have been rearrested. It's each client tracked for 365 days, out in the community. Have they been rearrested? Have they been reincarcerated? Or reconvicted if it's able for you to get that data. But each client needs this uniform follow-up period of 365 days, 1 year, in order to get a coherent recidivism measure. And finally, when you're doing your presentation, you can just kind of walk through these first 3 steps. What's the problem I want to address? Who am I serving? How did I serve them? What were the strategies? Did those strategies get implemented easily, well? What were some obstacles that I experienced? How did I overcome them? How many people were served in total? How many people completed? And then what were my outcomes? So this is our sort of nice analogy that will hopefully help you remember, what we're working for. Sorry. So, the spring is all the different sources of data. We can have information on these clients trickling in from multiple places, and then when it gets to the river, we can think about that as the compilation. This is how we aggregate all of our data to get the best picture of each of our clients. But at this point, you're not quite there. The big, analysis comes as the river runs through the dam and creates a ton of electricity. Now, granted, I don't think that your programs are going to supply energy to all of the southwest of the United States, but there is an opportunity for you to show, big changes and big impacts the way that this, dam produces big electricity. So, there are a lot of areas and a lot of places that we could get hung up in looking for data, because these are, flags and data points that everybody is going to need. Maybe you don't need all of them, but it is a lot of different areas of information to collect information on your clients. Have they been involved with the system before? Is this their first time in? Is it a jail or prison sentence? What assessments did they get? What are the outcomes of those assessments? What services are they getting? So for each of these data points, it's an opportunity to know more about your clients, but it's also an opportunity to get sort of lost in a bunch of different data sources. In addition to that, you're going to be dealing with multiple actors. So all of these actors have their own data sets. It's very complex, and you have to think about, where is the data for each of these actors? Conceivably, for as many actors as are on this slide, that's how many different data sets there's going to be, and there's going to be data kept in completely different ways. There's administrative differences with each of these groups. You're going to have to get all of them on board to participate. And the data set that's kept is going to be kind of a reflection of that system and the needs of that system. Because none of these places are collecting data for us to do experiments with. They're collecting it to be able to track people through their own criminal justice system and answer the questions that they have in their process. So, the types of data that these sources can give you, can be boiled down into three different areas. So first, there's computerized records, or case management systems. So this is individual level, line-by-line data. The next is statistical counts. Just, think about an annual report that you've seen, from anywhere. Aggregate counts, this many people in, this many people out, this proportion female, this proportion, demographics, and then finally paper case records. But with each of these sources, you need to ask yourself and find out at the onset of your program, who owns this data? Are they ready to cooperate with being able to share it with you? And in these data sets, what elements are available? And are these all of the elements that you need? So, for example, with the statistical count, the aggregate level data, it can capture a lot of different elements, but it's not going to allow you to break things out. So, an annual report can say 40% of our folks were charged with a property crime, 10% of them have severe mental illness, 20% of them are women, but that's not saying that 8% are women with severe mental illness that committed property crimes. It's just saying, it's far more discrete. And then retrieving it for analysis is the thing that kind of causes hiccups in each case. So paper case records, were these kept in a basement that was affected by a hurricane? Are these aggregate counts available online with easy access, or is it a tick mark kept in some manager's office? And then finally, with the computerized records, this is what you think of as, oh, this is the gold standard, it's great, it's going to have everything. But as I said earlier, the data systems to house this information were not created with research in mind. It was created to answer questions that these different points in the criminal justice system have about their clients. So, it may be easy to go to a terminal and look up individual by individual, but that's no better than a paper case record. You're going to want to, have some long talks with the different agencies and their IT departments about how easy it would be to extract this data on a large scale. Conversely, even if it is easy to extract on a large scale, you may have to go through, 4 different agencies to get each variable that you're looking for. And then you have to think, is there a way to match my client from my system to the jail system, to the mental health provider system, to probation? So is there a unique identifier that's going to, follow this person from place to place? Because although you may be serving 300 people and, you think that this is a unique name, you're not going to be able to just look them up by name. So you need some sort of state identifying number. And then finally, the quality of data. You're going to get some idea about this when you're talking to the different folks about their own system. They'll have some idea about if this variable gets rewritten every time a person has a touch with the criminal justice system. But sometimes you may not find out about the quality until you actually get the data set and start working with it. So there may be a field called assessment. Oh, great, they've got information on the assessment. Well, that field could be 70% empty. It could also have a big open text box that people could write 2 paragraphs about the assessment, which is far different than being able to have an easy score or categorization of the client. But anyway, so these are all things that just should be kept in mind as you're trying to extract the appropriate data. So this doesn't show up quite as well on screen as I'd hoped, but when we talk about creating a process model, the fancy term is the sequential intercept model. But just think about it as a flow chart. As a person has their initial contact with law enforcement, how do they go through the process until they're, out of custody of the criminal justice system completely? This is going to do a couple things for you. First, you're going to be able to do this with everyone in your area as they progress through the criminal justice system. So you'll have a nice baseline of the amount of people that the agencies are dealing with. You'll not only get a count, but you can also get kind of a time period that it takes for each of these movements. And then you can do the same thing with the folks that are being served in your program. So you'll have a baseline, and then you can have, the very specifics about your participants and see if the amount of time it takes for them to get through is different and in what way. But you have to make sure that there's a good analytical picture as you're going in and creating this sequential intercept model. So, I know that the goals of your initiative are probably pretty clear, and the target population is also pretty clear, but just make sure that you have, at some point track the number assessed for your program, and then the number referred in, the number that you select, and then the type of service packages that you're going to be giving to those involved in your program. And then the number of services that you're going to need to be able to give these packages to those referred in. And finally, once they get the intervention or service, we need to track those who complete, those who drop out, and then those in a comparison group. Making sure that you track the folks that are dropping out and then getting the outcome measures for them is a good way to show if your program is cost effective or not. So we looked at a program once, and only 40% of those who started completed the program. So 60% dropped out. But when we looked at their recidivism measure, it was exactly the same. So this is not a very cost-effective program if those people who did not get any treatment or the people who didn't finish their treatment ended up, recidivating at the exact same rate as those who completed. Additionally, we need to make sure that there's a comparison group that looks like your program participants but are not getting any treatment, so we can say, anything about the outcomes. So if I say, my completers recidivated at 70%, well, that sounds high, but, what did the comparison group get? Or if I say, my completers recidivated at 10%, well, that seems low, but again, if the comparison group is pretty similar, it may have not much to do with the treatment and a whole bunch to do with the target population. So, the only way that would be able to say anything is if your completers are recidivating at 100%, which is terrifying, or if your completers are recidivating at 0%, and all that really says is that you've probably done the recidivism calculation incorrectly. So here are some of our process measures that we use on a regular basis. So outputs are just going back to that intercept flowchart map. How many numbers of people are at each of these decision nodes? These are just an indicator of the number of times something happens, number of goods and services. We also do efficiency measures, which are, taking the number, from the production and then attaching a cost and reporting in units of cost or units of time. And this can show both cost efficiency and then, the type of inputs that we would need if we were to replicate this program anywhere else. And then our outcome measures, again, recidivism is our big measure. Make sure you have the same follow-up period for each person. And then quality of life, which I showed a couple slides back. This is sort of the point of most of your programs. So you guys are already doing this, and this is the thing where I'm just really stressing you want to identify your output measures before you even start accepting clients, so there's a way that you can address and retain information on these quality of life measures, because we know that this is already happening, but these are the type of things that you could really report out to different policymakers to show how effective and helpful your program has been in the community. Some ideas for other measures are in this a guide to collecting mental health court outcome data, and it kind of lists by different stages of the process, or so you can flip through this publication and see if some of these things very specifically speak to what you're trying to do in your program, and it'll be a good kind of template to work from as you go forward in collecting data. Additionally, the Petrilla study that I mentioned at the onset of this presentation is called Information Sharing in Criminal Justice. And so this can help you overcome these confidentiality barriers that are often coming up when you're trying to collect data and implement your program. So either of these are available on the web, so I urge you to look through them just to have a good background. And finally, after you, select the correct population, overcome, your lack of process map by making the sequential intercept model, come up with your good outcome measures, collect all your data, aggregate it, analyze it. Well, now you got to show it to somebody. So here's an example of a chart that is in this Allegheny County publication. It's very simple. Like when you present to people, you want to have something that they can look at and see, what it means quickly. So the people who participated recidivated at 17%. The matched group that didn't get the treatment recidivated at 33%. This looks good, right? It's like half the rate. So this is a very easy, clean chart to read and good to put in a presentation. You can also have more detailed information presented, like this from the Colorado Coalition on the Homeless. This is far more detailed than the thing on the last page. But again, it's very clean. Everything is simply labeled. Red means it's dropped. You can talk through it pretty quickly. This may be a better example of something that you want to put in a printed publication. But again, it's, still want to keep it simple and easy to digest. But here's a kind of, counterexample that proves the point. Don't do this. I don't I was trying to kind of work through this graph so I could explain to you what it means, but it would simply take too long. This is a really good study, and they wrote a really nice article, and if you go through the article about 10 times while looking at this chart, you'll probably get a good idea about what they're trying to tell you and the outcomes of their folks. But this is not the type of thing that you want to walk into a policymaker's office with and try to walk them through in about 3 minutes, because you probably won't be able to. The minimum level of effort for data, somewhat more difficult than the word minimum would suggest, but you'll still get a fair amount of information to convey to people, and using this data, you can kind of help sustain your program. So, on the left, you can kind of see the policy process that you may or may not remember from American government sophomore year of college, but interest groups have these ideas, they identify a problem, you get some community support, and then a policymaker takes notice, and they think, oh yeah, this is something that I would like to respond to my constituents with, and so they'll end up enacting a policy or program and allocating a certain level of resources to sustain this policy or program. Luckily, your program is there. It's labeled My Program. Hopefully yours is called something better. But, this program can, address this same concern that the interest groups have. And, with these resources, your program is shown to do a good job, have a positive impact on the community. A couple years later, people think, hey, there's this, pool of resources and I would like to help as well, or I've got kind of a different take on how we can address this same problem. Maybe I can go after this same pool of money. Now, the thing that you're going to have is data and performance measures indicating that you're doing a really good job and that you've affected the community in a cost-effective way over the past period of running your program. The other program is just going to have, a nice glossy sheet laying out what they want to do. So hopefully you can use this data to not only make, internal tweaks to your program to make sure you're serving your clients in the most beneficial way, but also present to the community and different policymakers that you've done it in a cost-effective way. So in summary, just remember that there's, different types of data and different types of questions that are going to exist at different levels of the process. And when you're presenting, you want to make sure that you're presenting the data that each of these people need. You're going to have to get it from a lot of different sources, make sure that there's a unique way to match the person from data system to data system, and that you're collecting all of the correct variables so you can calculate the outcome measures that you want at the end through your analysis. Drawing this analytical picture will help you remember all of the outcome measures and variables that you want to get, but it will also be a good way for you to remember to keep, data on the people that drop out of your program and keep data on a comparison group which looks like the people that start your program, and the only difference is that they're not getting the treatment. So you can show what would have happened if no one in your program got this treatment. And finally, once this data is put together in a simple and sleek presentation, then you can go to the different decision makers with your program information so you can continue sustaining your program into the future and helping new clients year after year. And just to prove that that's possible, I'm going to turn this over to Anne Marie to talk about her experience with cases and the Nathaniel Project. But my contact information is in that super easy to read yellow at the bottom. So if you have any follow-up questions, do feel free to reach out and I will answer or turn you over to somebody with a better answer.
Good morning, everybody. Hi. So I'm going to do the sort of on-the-ground practical experience, and I think Jessica did a really great presentation, but I think she didn't live the pain that we experience in trying to sustain our program. So I'm going to sort of talk about some of the successes we had, some of the challenges we had, and some of the lessons that I've learned in the years that I've been at Cases. And so I'll just tell you really quickly what Cases is. We're an agency in New York City, and we work with adults and youth who are involved in the justice system, generally providing alternatives to incarceration services. And in 1999, Cases decided to start a program with a little bit of money, $100,000, so that's not a lot of money, and that program has been sustained. I'm going to sort of talk you through the story of how we were able to sustain that program. And one of the smart things that I think that we did at Cases is that we listened to people that knew more than us. And so when I was able to come to a grantee meeting, I wasn't a grantee, but I was able to get into one of the SAMHSA jail diversion grantee meetings sort of in the year 2000. Dr. Hank Steadman, who was here yesterday talking about mental illness and violence research, said a couple of things, and I remember them and I sort of took them away, and they were sort of painful to me to sort of take away, because I was thinking, I've got enough to do, and I've got to collect data and analyze data and think about outcomes, and I was really busy. And so what Dr. Steadman said, he said that when you write an application for a program, you make promises. So you say, we're going to do this. This is our goal. These are the outcomes that we hope to achieve. But if you want to sustain a program, you need results. And so that, I sort of heard that, and I thought about that, and I was, wow, I never thought about that. Oh my God, we're going to have to demonstrate results. He also said that all of the programs, all of you guys are going to have success stories. You're going to have Jane and John and Andre and Michelle that you've helped, that you've improved their life. And that's all well and good, but everyone's got a great story that they can tell about a client who was impacted by their mental health court, the CTI program, the Veterans Court, the Juvenile Treatment Court. Everyone has those stories. And so, but what everyone doesn't have is really good data. So Hank said data, and I'm going to say data to you guys and hope you sort of take away that message. The other thing that Hank said is that when we start a program at this sort of intersection of mental illness and criminal justice, that we've created a model that we think is a great model. We think, this is what we want to do, and we're sort of in the program, we're working the program. And what he's found from his sort of research of jail diversion programs, which includes mental health courts and other sort of case management jail diversion programs, sort of forensic act teams. I know there are some folks out here who do forensic act as well, and sort of either through a mental health court or just a sort of traditional jail diversion program, is that program that you started, and so you guys now as grantees, whether you started the program last year, 2 years ago, or you're just about to start it this year with your case management team, the staff that you have from juvenile justice, is not the model that you're going to sustain. And so I sort of share that with you guys because that's the story that I'm going to tell at Cases. So be open to the fact that what you wrote in your grant may evolve over time based on your outcomes, and also based on the landscape, like the funding landscape might change. And so here's the story that we had at Cases. So we started the program. I was hired. We were doing case management in New York County as an alternative to incarceration for folks with mental illness. And so we said when we had applied for this money from the city council in New York City that we want to serve high-risk, high-need people. And so for us that meant, they're in the court system, they're arrested on a felony, but we didn't really know who they were going to be in terms of their characteristics. But we were sort of saying this high-risk, high-need folks. I think one of the good things that happened to us is that when the Nathaniel Project started, that we were in an environment of performance contract, that New York City had changed how they were delivering money, that it wasn't just a line item contract, that the notion of you're going to be paid for inputs and outputs, so how many people you get into the program, how many people you retain over a period of time you're going to get paid for, but also for outcomes, that there was a percentage of this 100,000, I think 15%, that was about outcomes. And so that's important that we were sort of in that landscape, and I don't know what your sort of funding landscape is in the jurisdictions that you come from, but clearly if we are in our sort of intersection going to use Medicaid in the future, and I'm sort of going to talk about that, like Medicaid is about outcomes. It's about, if people don't come to treatment, if you have no shows, you're not going to be paid. Do you know, if people drop out of treatment, you're not going to be paid. And so we, as in our intersection, want to use the opportunities that come with the ACA. I think we have to think about performance and outcomes. That's really important. And so we actually just started the program. We were only going to serve 8 people. That's what we got funding to do. That sounds like a very small number. I heard someone who was running a mental health court who was on a panel saying, we have 12 people in our court. If you have 12 people, that you have data about those 12 people. And so it doesn't matter how small your program is, how large your program is. Once you start having clients, it's really important that you start collecting data. And so from the onset, as I've had the opportunity over the years with CSG to go to do site visits, I think that folks think after we've run our services for a while, we'll start collecting data. And as Jessica just said, that you actually want to start collecting data beforehand. You want to create those systems, and however simple they were. So in our program, it was my job to go in, screen people. I was working by myself for the first 4 months of our program. It was my job to go to court and advocate for people to come out of the program. It was my job to take people to get Medicaid, to help people apply for SSI, to take them to the shelter system, to take them to housing. I was doing all of those things while I was also having a Excel spreadsheet. So I know there are some program evaluators here. Don't like the notion of the Excel spreadsheet, but you've got to go with your reality. So we were able, and it was just another task that I had to do, that for anyone that came in, I needed to know who were the people. So who were they? We'd said we want to serve high need, high risk people. It didn't really mean anything, but it was a great catchphrase to entice funders. But we had to sort of describe what was that high need. So both in terms of people's diagnosis, but one of the things that we've heard a lot about this conference is not just the diagnosis, but focus on the functioning. So that's an aspect that we were not doing in our early stages. The incidents of co-occurring, the charges that people came into, we just said, we want to serve people who are going to be convicted of a felony at risk of going to state prison. But the charges became very, very important. I'm going to sort of talk about that later on. And people's prior conviction history. I think that's just really important, that you need to know what your folks look like in terms of their legal history. And so in August of last year, we started a new program for women. And I can tell you today, we just started the program in August. We're in February, but I already have data on those women. I know that of those women, 54% have been to state prison. We've had 30 women come to our program. I know that 89% have served a prior jail sentence. And I know that on average, this cohort that we've just had in the first 4 months of our program are sort of being arrested at sort of 3.7 times, 2 times in a year on average. So I already know data. So it's never too early to know who you are serving in terms of your program. It's really very important for us, Jessica covered this, to know about the behavioral health status of your folks. And so because there may be other opportunities there, we think about behavioral health, substance abuse and mental health, but you may discover that you're serving people, and we know folks with serious mental illness have high incidence of health problems, and that might be a funding stream that you've not anticipated, but there may be many of your participants, your consumers, who have chronic health conditions. Or you may need to know that because you may need to develop a relationship with a primary care provider so that you can address those problems, which we know have impact on wellness, mental illness, substance abuse, and other factors. Also, who folks are in terms of gender, age, and race. And so one of the things to know in your jail, what's sort of the average age and what's the average age of the population. The focus of your intervention is to help reduce your jail, folks of who you're serving, your target population's incidence in jail. You sort of need to know the average age in our jail is 20, but the cohort we're taking out, the average age is 50. What's going on there? If the biggest cohort is 20, why are they not getting into your program? And also baseline sort of utilization. And you don't you're probably not going to have access to your local Medicaid data, the local utilization data, but self-report is a really helpful way to get that data. You can say to people, in the last year before you came to this program, in the year before you were arrested, were you in the hospital? Were you in the psychiatric hospital? Were you're in the emergency room, you can do it. And what Jessica was promoting is do it in a consistent way. So I was doing spreadsheets and sort of collecting very basic data. Wasn't going to analyze it. I was just collecting it in a very sort of simple way very early on in our program. What we did at Cases, though, is that we were very aggressive in using that $100,000 that we got to start the program. So we weren't just going to use that money to start the program and after the first year say, what did we find? Like when we had 2 clients, we were looking for additional money. So we leveraged the base money that we got to start looking for money. And I think you guys are in a really great position as grantees that BJA staff had said that only 15% of applicants were funded. So you're in a select pool. I think you use that as a way to entice maybe private funders, maybe your state agencies, maybe your local counties as a way to say, we're special. Do you realize the federal government's only funded 15% of applicants across the country and we were chosen? And so I think you're already, even without having program data, in a very sort of unique position. As we have evolved, we had to very early on look at who are we serving in this premise of whether you're serving people arrested for felonies, misdemeanors, people who have serious mental illness, people who have trauma, what do they look like? And so we were able to see very early some trends related to the folks coming in the door in terms of violent and non-violent felonies, and also the high rates of co-occurring disorder, but also the high rates of homelessness, which sort of said to us, we should go speak to the Department of Homeless Services to tell them we're serving a lot of homeless people, and so we were able to sort of use the information that we were getting from data to sort of really focus in. You guys can see that we sort of, in the first year, we really leveraged that $100,000, you see, from November to December to increase our staffing, to increase our capacity. So we were doing it continuously. We didn't see sustainability as at the end of this grant period, then when we're going to sustain. And so you guys, your program administrators, your program evaluators, and really need to be focused in on how are we sustaining this now. That's one of the take-home messages. I think it's just a really important one. And the more you can do, the more capacity that you can serve, so sort of increasing the number of people that you serve, I think is going to sort of help you. I can't guarantee you're going to be sustained. I've overseen programs that weren't sustained even when they had good data, and that's a lesson that we sort of learn, and it's sometimes to do with the economic climate, but you should be really sort of quite aggressive in really thinking about how we leveraging the money that we receive from BJA for our funding. This is just sort of early information about what the folks looked like, and so you see a lot of them were homeless. So that was a need that we knew we were going to have to address. We didn't anticipate that. And what was also interesting in terms of us speaking to local mental health and state mental health officials was the notion that 78% of them, so people with serious mental illness, were not engaged in treatment at the time that they were arrested, which is an important fact. And other researchers have sort of demonstrated this as well. The American Psychiatric Association, when they looked at who are the people who end up in our jails and prisons who have serious mental illness, they found this trend as well. It's really important for government because it shows that there's a niche that your program is meeting that the current mental health services are not addressing. That this is a crowd of folks that drop out of treatment, so the innovation of your program or don't access treatment is just a really important point that we were able to show. You guys see the high incidence of co-occurring health conditions. I think that that's going to be a really important factor with the ACA and opportunities for the ACA. What we know is that people with serious mental illness utilize hospitals more because of primary health conditions than psychiatric conditions. And so I think that in maybe next year or the following year when we have this grantee meeting, we may be talking about that more as well as an intersection point. And then you guys see in our program, which was not sort of federally funded, that 50% of the folks that came to us were convicted of a violent felony. So that's just an important point of knowing who your target population happens to be. So this is like simple data that we followed our folks. We looked at a consistent, unique period of time. So what happened after the participants were in our program for a year? 4% were rearrested on a new felony. 79%, you saw that high rate of homelessness. But in those first 12 months, we were able to get 79% sort of housed in supportive housing. And it showed us where we needed to target our resources and our energies very early on when people came out of jail, and sort of the retention number that we had. One of the things that I think that we were successful was telling the story of the program from the beginning of the program and knocking on doors for everybody. And what that was able to help us do is help us to engage government when they weren't funding us, that they felt that we were an important program, that we were raising the idea, we were raising the knowledge base of government who weren't addressing this issue, to be quite frank. At the time when we started back in 2000, they hadn't thought about alternatives to incarceration programs for people with mental illness. It was really the community provider groups within New York City who'd really sort of pushed this. And I think that sort of some of the initiatives that we've now seen in New York City has sort of come from that sort of program advocacy, that we were really engaging government around like what we were learning, both government and elected officials, and also I think most importantly the people in the state budget office we were talking to. And they know the numbers. They know what things cost in your jurisdiction. And we were able to sort of, in a very crude way, talk about how we were saving money. It wasn't a very fancy cost-effectiveness study. It wouldn't stand up to Jessica's scrutiny. But the folks in the budget office, though, they bought it. They really did. And so I think that that's just an important thing. And so this is again from looking at sort of recidivism, and we're looking at what happened in the year people came to our program. We're looking at unique, similar periods in time, the year before and the year after. This is very simple data, but that graphic really got, we didn't have an evaluator for our program, but it really got researchers and Dr. Hank Stedman actually really excited that he saw a potential, like he was like, well, that's quite amazing. That your cohort did 66 felony arrests and convictions in the year before you got them. The year after, there were only 2. You would imagine that there were going to be more, that your cohort had, in addition to the 66 felonies, 35 misdemeanor convictions, arrests, and then there were only 5. So again, a simple way to look at data. And I think this is important for program folks who are working with program evaluators, that if you are in the program, that the data has to help the program. The data must not frill the evaluator in answering a question that's not helpful to the program. That there could be really complex evaluation done and it does not help you sustain your program. It really needs to be the nuts and bolts that are going to tell the story in a very sort of simple way about your program, and not interest in evaluators very complex, interesting a question, an evaluation question. It really has to be about the nuts and bolts, about what is our program doing, what are we learning, who are we serving. We were able, because of this really simple data, to get Dr. Stedman and his staff at the Gaines Center they were really excited by our very, very simple data to sort of 2 years into our program, first in 2002, and then they updated in 2005, a program brief that this just described this program. And so I would challenge all of you that there is something very unique about your program, whether you are running a new mental health court in your jurisdiction, that there is something unique about your mental health court, that there's a story to tell. And you just have to think about what is the story about our mental health court, and I think that, and how it fits into other mental health courts, but I think that there is just some unique thing about your mental health court, your youth program, something that you can tell in a sort of program brief that sort of tells your story. And it's also like branding who you are. Like if you watch adverts, people can describe who they are, and sort of something like in New York City, we have intensive case management and ACT teams, but I didn't want to say, like we run an intensive case management program for people with serious mental illness who are in an alternatives to incarceration program. That what we said is actually we run an intrusive case management program. And people they heard that. And the prosecutors sort of bought into that. We want you to be intrusive. These people were convicted of felonies. If you're not intrusive, you're not doing the accountability that we need to ensure that the public is safe. And so I think that there's a way to find your story, find your uniqueness that sort of is going to come out in your data. We went for awards. I bet there are local awards in your jurisdictions. NAMI. like there are local NAMI chapters. Like these awards are still going. You guys should go for the same awards. We only had, remember this program started in January of 2000. In 2 years later, we were able to sort of apply for and get awards. I think that that's a really great way of getting government and stakeholders invested in the notion that people external to us think it's a good program. Like we can sell our programs as much as we like, but it's really the external folks that are sort of going to really sort of help us. And so minimum effort. I was once on a panel in New York City at some university sort of talking about the program, and at the end of it, a young woman came up to me and she said, I'm going to law school in the fall, but I used to be a research assistant. I was really interested in what you were saying. Is there some way that I can help you? And I was like, yes. We have lots of data in our spreadsheet. Could you analyze it? She was really smart, and she spent her summer analyzing this, our sort of program data, and she did a really excellent job. And so there are always opportunities. So I would say go out and sell your program. If you have 2 clients, go out and sell your program. If you're just about to start, go out and sell your program in your local community, whether it's universities or forums or NAMI or other environments, or go talk to folks if there are peer agencies in your localities, but just go out and sell your program because you don't know what opportunities come. And we were able to use this, the analysis that she did, because we didn't have time. Our staff were working in a really sort of intense way with the clients, and we didn't have money for evaluation. So this was sort of 3 just no-cost analysis of our data that we were collecting, but sort of didn't have the time to analyze. And so what she found was, our trend sort of continued, that she found that in using same uniformed period 2 years before and 2 years after now, because we're sort of later, that the decline in arrests, the average arrests at intake, the average arrest post, these are 2-year frameworks, and the decline in sort of convictions. And so when you're small, your numbers are going to be excellent because you're really focused. As you grow and you just have more capacity, they're going to even out. And that's just the reality. So when you're small, have data that you can show these excellent numbers because they're going to even out as you increase capacity. That would just be a rule of numbers. I'm not a researcher like Jessica, but I think that's a trend you're going to see. And so the other lesson that I've sort of learned about sustainability is actually continuous. And so as a grantee, it's not going to be that you have got this grant, whether it's a planning and implementation grant, that in sort of 30 months or a 24-month period that you have this grant that then you're going to sustain. You're going to want to know data all the time, what your outcomes are, what your performance is all the time. We are continuously sustaining our program. And so for us, like you guys can see that we've had different sources of funding, components that we have in our ACT team. Sometimes we get funding for 3 years, sometimes we get funding for 6 years, sometimes we get funding for 2 years, sometimes we get some just off-the-cuff funding that sort of helps us, but continuously we are sustaining our program. And this is the lesson for sort of program administrators, that part of your role, if you're the court coordinator, whoever you are, that you should be using the data in the loop with the staff on the ground, so in the loop with all of your stakeholders, but you should also be using the data for continuous quality improvement. Like we're not just using data to sustain our program, but continuously we're using the data for continuous quality improvement, sort of telling our story. But you always want to make sure that your performance in your program is continuous. The other thing that I think that we've learned at cases that may be helpful to you guys is the notion that these programs at the intersection of mental illness and criminal justice system need multiple sources of funding, that you are not going to find one source of funding for your program, that you need to blend funding. And so that's what we have done. There's core funding that comes from Medicaid for ACT in New York City. When we got our license from the New York State Office of Mental Health, and the state said to us, it's okay to serve people in alternatives to incarceration program, but you need to find the money to find those people and do that court work that you're talking about. ACT doesn't do that. If you want to do it, you've got to find the money. We have to find a way to find that money. And so we were able to use our sort of outcome data around recidivism to engage our criminal justice partners to say, this pays for, Medicaid is paying for the base ACT services, but we need these other funds so that we can find people in the jail, we can find people in the forensic hospital, then we can take people back to court for their updates. The other aspect of this is the notion, when I said earlier on that Hank said that our program was a case management program. We had some psychiatry, part-time psychiatry, but it was case management social workers who were doing this care coordination, linking people to services. So we were linking people to clinics, day treatment programs then in New York City, not so much now, supported housing, community residences, and we were following them. And what we learned in the experiences is that we didn't like so much what we saw. And so when the state issued sort of an RFP, that a lot of the time we were sort of problem solving with the provider. Our staff were spending a lot of time sort of problem solving with providers who had challenges in serving our clients, and we really had to be competitive in selling our clients to the providers. And so when the state came out with its RFP for ACT, they didn't come out with an RFP saying, you can do ACT for people that were justice involved, but we were pushy and we said, can we do ACT for people that are justice involved? And I'm not going to say that the state was like, oh, yes, you can do that. They were skeptical about it. People at the state office were skeptical. They sort of said, but ACT is not for people with personality disorders. We said, we know that. We're trying to serve people with schizophrenia. But people with schizophrenia in our jails? And so I'm not being naive. This is what was sort of said to us. And I was like, yes, they are, because I remember that before I went to cases, I worked in a state hospital. And the first 2 people that I ever screened were people I served when I was in the state hospital as a social worker. So we were sort of helping state officials appreciate that, yes, they are. It's just a different door of entry into our mental health system. And so there's some, and I think that this is an important point about the data, that you can use your program data also to educate the system. I think that that's a really sort of important point. But, if one of my take-home messages is going to be, think about blended funding sources. Think about the Affordable Care Act and what opportunities there might be in terms of sort of blending sources. One of the great things that sort of has happened with us is that we have got criminal justice partners like the Office of Probation and Correctional Alternatives, who are here as a grantee now, to pay for mental health services. Which is sort of very interesting to us, that they paid for us to have an enhancement with a supported employment social worker on our ACT team. So it's criminal justice money is being used in a different way. And so I think there's also an opportunity there around sustainability to both educate your jurisdiction around it, but also get people to sometimes think about this concept, which the woman who used to formerly run OPCA used to describe the shared population. She was a very smart lady, and she sort of talked about, this is a shared population, so how can we all contribute to it? So I think that's the selling point, if you guys want to take that away with you, shared population, that everyone needs to pay into this process. And so some of the things that we've learned, Jessica talked about, who's your target population? Remember I said when we started, we were just saying in a very sort of generalized way, we want to serve high-risk, high-need folks. Well, we've got better at it in terms of defining who they are. That when you run your program, there are going to be, I can guarantee you, I believe there are going to be opportunities that you don't know are opportunities that come. And you need to really sort of take those opportunities and sort of run with them. And you need to sort of, again, sort of think about the problem that's being addressed. What is the story of your program? You need to find your sort of niche around the story of your program. So data changes over time. You guys can see that chart in terms of who are our referral sources at cases. And so I just looked at 2 points in time. And so this is not so important in terms of who are our referral sources, but this is in terms of who gets into our program. And so you guys can see that in, I think it was the year sort of 2006, there was a psychiatrist that worked in our forensic hospital where folks go after they have been found incompetent after arrest. And he just called up our intake coordinator and he said, I have a guy that's here who, when he goes back to jail, I don't want him to get sick again. And can he get to your alternatives to incarceration program? And our intake social worker said, yeah, when he gets back to Rikers, I'll screen him, like I do other people. And the psychiatrist was like, no, you don't get it. I think when he goes back to the jail, he might get sick and then he might come back to the forensic hospital. And I want him to be able to get into your program. Why can't you come here? So the intake person said, I don't know. Okay, I'll come. So he went. And over time, what we have found for us is that the forensic hospital is a better source of referrals, that it's helped us reduce our the utilization of our intake specialist who's paid for by criminal justice money, it's helped us reduce the negative referrals, the referrals of people who are not eligible for our services. And so this is where data really helps you to sort of both tell your story but also improve your program. And so we created a system through that phone call that we never initiated with a psychiatrist asking us to come and help to really find a good pool of people who are eligible for our program. And so that's the notion of there are opportunities that come that you don't anticipate, that you really sort of need to utilize and then tell the story. And so this is a good story because it also became a source of money. And so 2 years ago? No, last year, Jerry? 2 years ago? So every 6 years, one of the Mayor's Office of the Criminal Justice Coordinator in New York City issues an RFP for ATI services. And so we've historically got that money. We wanted to actually, this time around, ask them for more money. And so, did we get them more money? Yes, we did. Why did we get the money? Because of data. And so I'm going to sort of tell the story. And it's interesting about who holds the data. And so I was able to call up Donna Hall, who I believe is here from the New York State Office of Mental Health, and say, Donna, they've issued the RFP, and we want to demonstrate that the intake person that they fund is being utilized effectively. And so because a lot of our consumers were coming from the state hospital, we sort of said, what I asked her was, I said, can you help us look at what happens in the utilization of the state hospital with the folks? And she said, I can do better than that. I can actually look at your data and compare it to a random sample of people who are matched. So she compared it to a random sample of folks who were in New York County, who were found incompetent, who had similar arrest histories as our clients, who went into the forensic hospital. And so what this sort of tells us is it tells us $16,000. And so you guys say, tells us $16,000? Yes, it does. And I'm going to tell you how it tells us $16,000. What they found is that our consumers, where our intake person goes in and gets referrals from the psychiatrists at Kirby and screens people for our program, that they stay less at Kirby. So they stay 89 days on average, the medium length of stay, compared to that random sample who stay 109 days. And so why is that $16,000? It's $16,000 because the average day stay in that hospital is $800. And so even before someone comes to our program, we save money potentially. That's interesting. Also, you guys can see that the individuals that have been identified that we've screened in that at Kirby, they're less likely after they've been returned to the jail to return back to Kirby for a second admission. And so that's how it speaks $16,000. And so if you were to ask me or ask Jessica, but what does that mean in terms of data? I don't care. Like our intake person would say, I think that what happens is that people have hope, that there's something, and so we can't measure that. Jessica, can we measure hope? We can't measure hope, but he would say, I go in there, we've identified people who are getting well to go back to jail and not know what's coming, but he's identified people and is saying to them, maybe we can help you, I don't know. And what happens is those individuals call him and they establish a relationship with him. What have you heard? What's the prosecutor saying? What's my attorney saying? Are you going to come and see me again? And he's sort of reinforcing, yeah, but if you want to come to our program, you've got to stay on your medication. And so maybe there's something going on there that we can't measure and our data's not going to reveal. But for us, it's sort of important. It sort of told this story of how you can reduce the length of stay in a very important place, a very costly place, I have a few more minutes. I should stop. Even before someone's come to the program. So that was just one of our stories. I'm just going to leave you guys really quickly about this risk-need framework. And so I think when the first cohort of grantees came to the technical assistance grantee meeting, no one was talking about risk, need, and responsivity. But you guys have seen the charts in every breakout room. We've heard a lot about it. And please don't ignore it, because I think that if you're thinking about sustainability, that this is going to be one of the things that's going to help you sustain. So regardless of what instrument you use, you need to know who your people. Remember I said when we started in 2000, we say we serve high-risk, high-need people? Well, we have over time through data are able to really identify that. And so when we've started using a validated risk assessment, we just happen to use the LSCMI, whatever instrument you see how our participants are distributed in terms of the different risk groups. So you see that. So that's important. You need to know who are you serving. But the more important story is in your group, what are the issues? And so we had evaluators just do a very discrete piece of work for us. And we asked them a couple of questions. So discrete piece of work, time-limited piece of work, it's not continuous program evaluation. We asked them to look at, are we using the tool in a validated way? What does it say about the participants? Is it a good tool to be using with our participants? And so they found that, yes, you're using the tool in a validated way. And they said to us, and what do you do about antisocial peers in your program? Because that was the thing that stuck out with them. So they found in in their assessment of our LSCMI and use of the tool with our participants that for every unit increase in score, so even if you were in the medium category, if you were a 16 or a 17 or an 18, for every unit increase in the score, it increased by 13% the likelihood you were going to fail. So the categories are important, high, very high, and medium, but also within the categories. If you were scored 13 or 14, the fact that there's a 13% more increase in likelihood that you would fail our program, even within that medium category, is significant. So I'd encourage you guys, if you're going to use a tool, and really have someone look at what does it show us, both in the aggregate as well as what the report is saying for each individual person about the dynamic risk factors. What the tool also, the thing that stuck out for the evaluators was the notion of antisocial peers. And if you would ask my staff, why do people fail your program, what do you think our staff would say? Yeah, they would say substance abuse. It seems that it's not substance abuse. It seems that it's that people hang out with antisocial people and then they use the drugs. And so we can intervene in the antisocial friends that they have. Maybe we can both reduce the substance abuse and the likelihood of sort of failing in the program. The evaluators also looked at, does diagnosis matter in the use of the LSCMI? They actually found that it didn't matter. That if someone had paranoid schizophrenia, someone had bipolar disorder or undifferentiated schizophrenia, it sort of didn't matter in terms of where they would land in risk score, nor did it matter in terms of the likelihood for them to succeed or fail our program. And just finally, so now we know who we're serving in terms of risk. So we know what our curve is, what our distribution is in terms of the different risk categories for our clients, but we also know how they do. And so this is another refining of the data. We know that if you come into our program and you're low risk, in the 2 years afterwards, about 15% of that none of those people get arrested, So you guys can see that at the top, it's 15% of who we serve are low risk, and none of them get rearrested in a 2-year window. We know that the medium, those in that medium bracket, about 30%, and we know that about 52% of those that are in the high and very high categories get rearrested. And the Michigan comparison is just what's in the LSCMI manual. It's the group of mentally ill offenders who they had in the manual, who the manual is sort of normed against. And you guys can see that they have higher rates of rearrest. So their low-risk group, who accounted for a larger sample than ours, 37%, it's only 15% of ours, 28% of the low sample were rearrested. And you guys can see their sort of high and very high was only 18% of their sample. It's 50% of our sample. 52% of our sample was rearrested who were high or very high. So that to me is sort of worrying. I'm like, oh my God, 52% of them get rearrested. But in this sample, 73%. So we seem to be doing. The other aspect of the data is what I just wanted to conclude with is in knowing your data. So 52% of your folks get rearrested, but that is very low-level misdemeanor arrests, sort of jumping the turnstile criminal trespass, that we in our program for the sample, remember we sort of said that 50% come into the program on a violent felony, that we have like a 2% rearrest rate for another violent offense, anything, misdemeanor violence, felony violence 2 years post the program. And so there's sort of context to what the rearrest is. So when you look at your data and your rearrest, you want to sort of drill down into it. And on that note, I think, do we have time for questions? All right, great, we do have time for questions.
The use of a spreadsheet is not something that is somewhat frowned upon. And one of the things that we were talking about at the first day is to have a database. I mean, each program has to develop a database. The extraction of the data is a challenge in some ways, but we're finding that actually the development of the database and the analysis of that database is a little bit more challenging than actually the extraction. Is there a concern if we were to begin to share databases across different types of programs? So if you have a mental health court, or if you have a drug court, or a juvenile court, or a veterans court, because BGA is looking for certain information. And if we have a database that captures that particular information, why would we not share that so that each program doesn't have to spend money to develop that, and that we can continue to enhance that? I don't know if you have any thoughts about that.
I mean, I couldn't really imagine why there would be a problem with that, but for two problems. So the first is, some of the programs have slightly different information, so you would want to be able to tweak the data so you're not asking a bunch of juvenile questions of veterans. And then the second problem would be, we just need to make sure that it goes through a fair amount of beta testing, because, if there is, a slight issue within the database developed that's then going to be shared, we're going to have this, same kind of error showing up across everyone else's data set. But honestly, that seems like the best utilization of thought resources. If everybody can be, using the same thing, not only is there going to be one developed and not everyone's going to have to spend a ton of time making something, but you'll also have an automatic built-in network of people to talk to about, kind of questions and concerns, or fun tips and tricks. I don't know if they're really fun, but tips and tricks that you can, share.
Just to follow up on that, then, if there's something that CSG, and I've talked to Alex and Eric and Jessica, that we will provide a database, and then if there's some way that we can continue to have that assessed either by BGA to say this is a good one, this one works really well, and these are the pieces you have to be mindful of and watchful for. But I think that would really go a long way for all of our programs, and so I appreciate your efforts on that.
I was wondering if y'all could talk about some other things than recidivism that are the most compelling that we might be measuring. Our agency has a pretty good track record of programs that have been shown, evaluated, and have reduced recidivism. So in more recent years and with sort of changing landscapes, I frequently get asked, what else can we measure? And I'd like to be able to justify what I'm recommending.
So I would say two things. The first is those quality of life measures, right? Because that really kind of takes the burden off of a specific, city or county, and kind of, allows the person to have access to a lot of different funding streams. Maybe if you can get them signed up for Medicaid, or if you can get them back on track with getting their veterans benefits, some of these things just end up lapsing, and people have no idea how to reach out and get these resources in the first place, or to begin with. The examples I used in my presentation, I think, one of them was, people who have housing needs that get housed. These are all kind of quality of life issues that directly impact the folks going through your program, but then are also things that are going to have ripple effects into the community. So if you, tell a community person okay, well, this person has gotten their Medicaid and they're, now in some temporary assisted living situation, these are things that they're going to think okay, well, this isn't, money out of my pocket at the emergency room, and I no longer see this person when I'm waiting for the bus. So that's, going to be kind of an easy thing that they can see. And then the second thing I would point to is that document that BJA has put out that has all sorts of outcome measures, and you can, look through it and find things that are very specific to the people that you're targeting and things that would really speak to your community. Now, I'm not sure where everyone is from, but I know that you guys each have, some headline-making cases or needs or issues in each of your specific areas. So if you can tailor the type of outcome measures that you're collecting in addition to the, standard recidivism, number of people served, cost effectiveness type things, that would probably get like some good press play and some good, policymaker attention, because these are the type of things that, they're reporting on all the time or getting questions from constituents on all the time.
I had a question about evidence-based practices and whether your Nathaniel Project, intensive case management, was considered an evidence-based practice, and was your ACT team a full ACT team with fidelity to the model?
Great. And so the case management program that we ran, I would say, was not a evidence-based practice. It was case management. Like staff had a caseload, and case management has a lot of evidence. But the ACT team is licensed by the state, and so we have to meet the fidelity that's established by New York State. So we have all of the components that we know that, particularly around FACT. FACT is not an evidence-based practice. It's a new, emerging practice within ACT. And there are programs that call themselves FACT programs, that don't have a psychiatrist, that don't have a nurse, that don't have all the components. We have all of the components in our program, and we're assessed, sort of for our license and every year by the City Department of Health and Mental Hygiene to make sure that we meet the standards.
One follow-up, what is length of stay in the programs?
Right. So this is an interesting. It's a really great question. When we were able to get the license to run an ACT team, New York State was saying ACT was unlimited, that there was no length of stay, and we, in our proposal to them, had written that on average we think people are going to be with us for just over 2 years, and they said take that out. And so, but our average length of stay is around 2.5 years. And what's interesting is because when New York State rolled out ACT statewide, with limited capacity, our teams have 68 slots. I think there are about 42 teams in New York City. What the state and the city found was that there are no more spaces, that they have people in hospitals who can't get into ACT. And so they've been doing a transitions project with some researchers to really get ACT teams to change that. And we're able to use us as a model to say that they are able to get people stepped down within 2.5 years, that other teams can do that.
You were reporting on the big four criminogenic needs. Were you also tracking how many needs were targeted by ACT, by your treatment, or were you just tracking recidivism rates per criminogenic need?
And so we're in the midst of doing both. The data that I was showing was what the researchers highlighted from their analysis of our data. The big four really did matter. Sort of even with a population, 80% have schizophrenia, co-occurring disorders, high percentage of previously been in state hospitals, that it does matter. And what I'm sort of now doing as one of the program administrators is really helping our staff focus in on how we're addressing those things. And so for me, I'm sort of interested, in our ACT model, we run a sort of integrated dual disorder group. We have a substance abuse specialist who runs that group. I'm sort of asking him, and who comes to that group in terms of, like scoring high for substance abuse on the risk score. And so we're really trying to use the instrument. And so this is what we were sort of told yesterday for each individual person, you want to make sure that the responsivity is really addressed by what the instrument, the risk and need instrument, is telling you. So that's what we are sort of doing now. And sort of my hat as the administrator is to really make sure. But if they don't come to the group, how are they getting that intervention? How are we sort of addressing it?
So I am sorry to cut it short, but we have reached our end time, and clearly it was a great presentation and great questions. First, would you just join me in thanking our panel, please?